Today, I discussed this morning is this overview of a PNH and the diagnosis and when and which patient to test for PNH for using the flow cytometry, and which patient have a risk factor for thromboembolism and early mortality. Finally, I discussed with the treatment of PNH. And the main pathophysiology of PNH is the somatic mutation of the phosphatidylinositol glycosyl class A gene, which is a prevent of generation of a G5 anchored protein, which, for example, the CD59 and the CD55. And the CD59 is a defense and the protection for the red cell from complement-mediated lysis. This is a complement cascade in the cell surface of a red cell. And the CD59 is a block, prevent the complement activation furthermore. However, if a patient in PNH have absence of CD59, has the progress to the terminal complement complex formation and the complement activation. And the normal cell protection from the complement attack by the presence of a terminal complement inhibitor in CD59. So they were survival and intact red cell. However, if a patient in PNH, if no CD59, this PNH cell without CD59 complement activation, this red cell is raised and leading to chronic hemorrhages. And this raised PNH red cell and the prehemoglobin released into plasma. And finally, this released free hemoglobin has manifested various clinical manifestations. For example, the thrombosis and the renal failure and the pulmonary hypertension and abdominal pain and dyspnea, which is lead to eventually a significant impact on survival. And dysphagia, fatigue, independent of anemia, and hemoglobinuria or some patient electrolyte dysfunction have a significant impact on the mortality. So some mechanism involved in this clinical manifestation is this free hemoglobin has increased nitric oxide consumption, and the patient in PNH has a decreased nitric oxide, which leads to vasoconstriction and the smooth muscle contraction. So the patient have a pulmonary hypertension or abdominal pain in smooth muscle contraction or the bowel ischemia. And if a patient manifests the comes negative hemolytic anemia or hemoglobinuria, we have to check to the PNH. And some patients with a marrow failure, including A+ anemia or MDS, or unexplained cytopenia, have to check the presence of a PNH clone. And finally, unexplained thrombosis, also suspicion of a PNH. And the International Clinical Cytometry Society recently recommend the PNH test in following clinical circumstance. First is the intravascular hemorrhages with unexplained hemolytic anemia and abdominal pain, or thrombosis or cytopenia. And the second one is a thrombosis with unusual location, which is a hepatic pain or intra-abdominal pain or cerebral sinus with the hemolytic anemia or with unexplained cytopenia. Or finally, the patient has the marrow failure, including A+ anemia or MDS or unexplained cytopenia. This flow cytometry is easily done on the patient peripheral blood. And the guideline is the ground site and at least one additional cell line should be evaluated. For example, red cell or monocyte population. And the routine analysis of flow cytometry can detect PNH clone at 1%. However, recent development of flow cytometry high-sensitive analysis can be detected even in the clone size of 0.01%. And what is risk factor of thromboembolism and mortality in PH patients? A long time, the UK, Dr. Hillman published that 80 patients of PNH have a long-term survival. As you can see, this is a patient with the PNH, and this is age and sex matched general normal population. So this PNH patient has significantly poor survival compared to normal control. And the French study, the PNH patient with 220 patients, they look at the poor prognosis factor in the long-term survival. The main factor is thrombosis and the renal failure and the evolution to secondary coronary disorder, for example, aplastic-anemia, MDS, or AML. And old age more than 55 years old, or thrombocytopenia at diagnosis. This is a French study. So we, Korean PNH risk data, looking at the patient with 301 patients, we analyzed the risk factor for thromboembolism and mortality. As you can see, the cumulative risk of thromboembolism in our population is 18%. And note, 11 patients developed thromboembolism within 1 year, and 14 patients within 5 years after diagnosis of PNH. What is risk factor for thromboembolism? Using multivariate analysis, the 3 factors identified. One is hemorrhages, as measured by LDH more than 1.5, the upper limit over normal, has a significant risk of the thrombosis. And impaired renal function has also independent risk factor, and the patient with abdominal pain with nitric oxide depression or bowel ischemia has also independent risk factor for the thrombosis. However, if we categorize the clone size of granulocyte at diagnosis, it did not risk of thromboembolism, which is suggesting that the patient with a large clone size or even or small clone size can be a similar risk of the thromboembolism. And overall survival is of our patient cohort is here. And when we compare to age sex matched normal population of South Korea, has a significantly inferior poor survival is here. So which means the standard mortality ratio relative to normal control is a 3.9-fold higher risk of mortality compared to normal population. So we have checked the risk factor of mortality. As you can see, the thromboembolism is independent risk factor for survival. And abdominal pain and the impaired renal function and the hemorrhages has also affect or risk factor for early mortality. And or not, the patient with the thromboembolism is a 14-fold higher risk of mortality compared to the general population. And the patient with the impaired renal function has a 7.8-fold higher risk of mortality compared to the normal population. And the patient with abdominal pain and hemorrhages has around 5-fold higher risk of mortality. So if patient in PNH is uncontrolled complement activation lead to hemorrhages as measured by elevated hemorrhages. These hemorrhages are leading to reduced kidney function and abdominal pain, dyspnea, chest pain. And this is eventually lead to end organ damage, including thrombosis, and renal complication, and the GI complication or pulmonary hypertension, and cause some risk of increased mortality and poor outcome. And the traditional and historical management of PNH is transfusion if a patient is hemolytic anemia. But this is transient. And for the risk of thrombosis or treatment of the thrombosis, we use the anticoagulant. But this is a risk of hemorrhage, especially in the combined in the aplastic anemia. And some studies suggested that this anticoagulant is ineffective or suboptimal in many patients. And the red cell supplement may be expandable clone and the elevated hemorrhages. And most physicians use the steroid, but many patients suffer from the long-term use of steroid of side effect. So definite the treatment is stem cell transplant or anti-complement therapy using eculizumab. So this PNH is a chronic hemolytic disorder. Transplant is only potential curable treatment. But as you know, the transplant has a risk of graft-versus disease. Recently published from Italy, the number of 23 patients is around half of patients experienced chronic GVHD, and long-term survival is around 60%. And the French study is a similar prevalence of GVHD, around half patient. And if patient with a chronic GVHD has decreased quality of life. So the transplant recommended for PNH patient with life-threatening cytopenia, for example, severe aplastic anemia or MDS, or possibly patient with disabling hemorrhages or thrombosis not controlled with existing therapy. And we look at our risk data for patients with 39 patients who received a transplant from related or unrelated donor, as the 28% developed acute GVHD more than grade 2, and 42% and chronic GVHD. And my patient of chronic GVHD, the 75% has extensive time. However, if we look at the long-term follow-up up to the 20 years, none of patients developed the recurrence of PNH. This is the survival data of a transplant is 39 patients, rounding the 79%. But we identified that the survival is quite different according to the conditioning regimen. A patient have receiving the reduced intensity with the fludarabine-based is a better survivor compared to myeloablative regimen, mainly in the Busside regimen. And next is anti-complement therapy. This is a complement cascade, as I already discussed. Complement is complement 3, and followed by C3 and the C5. And the C5b and the C5b9 complex has caused hemorrhages in PNH. And the eculizumab is binding the C complement 5. And this terminal complement C5 and the C5b9 activities completely blocked, and preserve the proximal function of a complement. And the two randomized clinical trial has already published. One is a TRIUMPH trial and the SEPARD trial. And the both study demonstrated it patient with the eculizumab has a sudden decrease, it improved the LDH level is 1 or 2 first dose, and sustained the LDH level. And in control is a placebo group who did not decrease the LDH level, has switched to the eculizumab at 26 weeks after treatment. And they all switched group also decreased the LDH level. And this patient also extension study. And for the transfusion, the overall transfusion requirement with or without eculizumab is significantly decreased the transfusion requirement in patient receiving the eculizumab. And subgroup analysis who had received the transfusion amount before study enrollment in past 1 year, according to 4 to 14 unit or 25 unit or more than 25 unit, there's also significantly decreased the transfusion requirement in patient in eculizumab therapy. However, some patients have a minimal transfusion in eculizumab group, has some concomitant marrow dysfunction may be continue to require minimal transfusion. And the other study is in study the Selford or triangle study have demonstrated that reduction of thrombosis. This is 39 event of thrombosis before eculizumab. However, after eculizumab treatment, significant reduction of thrombotic event. And finally, last year, the UK group published the long-term data of eculizumab therapy. This is a patient with survival of eculizumab therapy, and they compare to the normal age-sex matched control. As you can see, this is a very similar survival of the eculizumab therapy up to 8 years. And again, they compared the eculizumab patient and compared who did not receive the eculizumab. This is a significantly different survival with patient, between patient with eculizumab or without eculizumab. However, this eculizumab is the risk of a meningococcal infection. The patient must be vaccinated meningococcal vaccine at least 2 weeks prior to receiving of eculizumab. So let's discuss the comparison of two treatment modalities, the stem cell transplant or eculizumab. Okay, the transplant is a curable modality. However, we have to consider the risk of transplant-related mortality, 10 or 30%, and the long-term complication of chronic graft-versus disease. However, eculizumab, I'm not sure, but the risk of meningococcal infection. And the survival of the 60 or recently developed 80%. But eculizumab is similar to that of general population. And the advantage of a transplant is combined with aplastic anemia or MDS. But this advantage of a transplant is age factor. If a patient more than 50 is a risk of transplant related. And we have the HLA matched donor. And eculizumab is advantages we don't need a donor and improving quality of life. And also feasible for patients with comorbidity, for example, thromboembolism and renal failure. However, this advantage of eculizumab is long-time treatment and did not upload the neutrophil count below 500 and vaccination as a recommended guideline. So conclusion of my talk is the PNH is a progressive and life-threatening disease, not only simple anemia patient. And the lack of complementary inhibition underlies the morbidity and mortality. And patient with intravascular hemorrhages, bone marrow failure, or unexplained thrombosis has a high suspicion of a PNH confirmed by flow cytometry. And the treatment of a transplant or eculizumab. If you consider the transplant or eculizumab, you have to patient selection such a following factor. If patient has comorbidity or thrombosis or renal failure, or as a PNH patient, the dynamic as a clinical course, so you have to decide the timing of a transplant. And you can expect the transplant outcome at your individual patient. And you have to consider the age factor. Age is more than 50, it's harder to do the transplant. And the patient is below 18, is not approved in the eculizumab in certain countries. And of course, availability of a suitable HLA matched donor and the concomitant cytopenia And finally, patient choice to transplant or ectodermal. Or finally, patient experience, especially for the transplant. Thank you very much.